Thank you so very much. This was an incredible introduction. This was an incredible day. One talk is better than the next, and I'm the last speaker, so please bear with me, and thank you for staying till the end. And like everyone else, I have to say I'm in awe of this organization and your skills and your extra talents that I learned about today as a talk show host. I have to say your video is far better than Bernard's. Sorry, Bernard. Far more impactful, I think, for what it means for the care of babies, interviewing those giants in the field. So thank you for including me today. So this is a very exciting day. So my topic is going to be on mesenchymal stem cell derived exosomes. So there are not that many studies on this, so it won't be a long summary of many, many studies. So hopefully it will be a shorter talk at the end of the day. I do have a conflict of interest to disclose, and I'm happy to say this. I'm an inventor of IP technology that's licensed by Boston Children's Hospital to United Therapeutics, but this doesn't influence at all the nature of what I'm going to say. There are three basic components of my presentation today. I'm going to briefly touch upon the mechanisms of lung injury in BPD, which I think everyone knows, but I will sort of put them all together. I will talk about mesenchymal stromal, or also known as stem cell exosomes, in treating BPD, the evidence that exists from preclinical models, and also touch upon the promise and cautions, really, of stem cell-based treatments for BPD. And as we heard today from more than one speaker, it is not just BPD. This is a systemic illness, and also the disease that is associated with other organ injury. So what we do for the lung affects the other organs, and whether it's MSCs or exosomes, maybe it's one-stop shopping. You're going to target many diseases, at least that's the dream. So what is the BPD phenotype in 2017, 50 years later? There's still lung inflammation. Now, however, there's more alveolar simplification and decreased number of alveoli, thickened alveolar septa, and of course, significant dysmorphic vascular growth and pruning of the distal blood vessels. There's associated pulmonary hypertension that was really beautifully described by Steve Abman. Overall, there's less fibrosis, less cystic changes, and less scarring, less of the old, which was so prominent in the old BPD. So we call this arrest of lung development, but I'd like to propose that perhaps it's reprogramming of lung development. There is still lung growth that continues, but it's probably abnormal or different, or definitely dysmorphic changes are noticed. So what are the putative mechanisms of lung injury? There's ischemia, there's reperfusion, there's infection, there's inflammation, and as we also heard today, a lot of this has happened prenatally. This leads to tissue damage, again, prenatally, perinatally, postnatally. And a lot of cells are injured, but as we also heard today, there's progenitor cells or stem cells in every organ, including the lung. And it's highly likely that this injury alters the function of these stem cells. And there's data that Bernard nicely presented about the dysfunction of the one type of progenitor cell, the endothelial cell colony-forming unit, in the lung of BPD models. So there's this injury that happens in utero or perinatally, and the other thing that happens once a baby is born is that the placenta is sharply removed. And the placenta produces a lot of trophic and gives a lot of trophic factors to the baby, including oxygen, including important molecules, some of which we know, some we don't know. So there's a sudden separation of the placenta. And in addition then to the injury of the organs, there's probably loss of other nutrient factors, further impacting the stem cells of each organ, including the lung. And this could lead to tissue simplification and some degree of fibrosis. Rather than having now a normal lung develop, we end up having a BPD lung. I want to highlight this article that was published in 2015, which is really the outcomes, a 20-year survival and outcome of over 34,000 preterm infants, less than 28 weeks gestation. This is from the network, NICHD network, between the years of 1993 to 2012. These are the years that were covered. And what's exciting is that more babies survive. Most morbidities, the rate goes down. However, the frequency of BPD has increased. And what was interesting is that it increased even in the older cohort of patients, not just the 23 and 24-week infants that are now surviving, even the bigger babies. So that's a problem. And then this year, there was another article that came out, this is now from the Australian group, that actually looked at 3 periods in time, early 1990s, and 1997, and then 2005, and basically looked at their outcomes at 8 years. First of all, what we know is that the invasive ventilation is no longer used as frequently. There's a lot more less invasive ventilation, which we say causes less lung injury. And obviously, that's very important. What is worrisome is that there's a higher rate of oxygen dependence at 36 weeks, regardless if that's the right time to look at Roberta. But more worrisome is that there's worse airflow function at 8 years. And this is the era that more CPAP is used. And so the question is, as we heard earlier, that CPAP actually may enhance normal lung growth and development. In this study, that's not what's being addressed, but in the era that more CPAP is used, we're not seeing a decrease in BPD. So what does this tell us? We need to think of other ways to approach the disease, and I'm going to follow Dr. Bernard Thibault's talk on regenerative medicine, and that's where we're focusing. We're specifically focusing on mesenchymal stromal cells, stem cells, and their potential use for the prevention, treatment, and reversal of bronchopulmonary dysplasia. You already heard that these are derived from many tissues. They're easily derived from the blood, from the bone marrow, from the placenta, from adipose tissue, and the umbilical cord stroma, the Wharton's jelly. Not just the blood, the Wharton's jelly, which is a discarded material. It's actually a very easy source of cells. They're immunoprivileged. They have low expression of MHC1 and 2, and also the co-stimulatory molecules. Therefore, they are amenable to allogeneic transplantation. So my MSCs can be given to someone else. They can differentiate into multiple lineages, primarily cartilage, bone, and fat cells, but also liver cells, muscle cells, cardiac cells, nerve cells, etc. And their use has actually been approved for the treatment of graft versus host disease in children where this is steroid resistance. This was approved in Canada in 2012 and also in New Zealand, but not in the United States yet. To date, there are more than 500 registered clinical trials using MSCs, so just about any disease you can imagine, not only the lungs, the heart, the brain. And actually a phase 1 MSC-BPD study was published in 2014 from Korea, and I believe they've completed the phase 2. I am not 100% sure about that. Perhaps it's ongoing. Bernard says they're not finished. Bernard made this point very importantly. It's really, really important to characterize your cells. One thing that I should mention is if you look at one marker that will identify MSCs, you're not going to find one. And you do a positive and a negative selection, but really what you also have to show is that they can differentiate in culture to, in this case, osteocyte, chondrocyte, and adipocyte, because all the other markers that we use to demonstrate are present on these cells, they are the exact same markers of fibroblasts. So just markers is not good enough. MSC treatment has shown promise in preclinical models of BPD. We've heard about that by Bernard. And we also know that the therapeutic capacity of MSCs is really in their secretome. In fact, any model you look at after MSCs are delivered, you can't really find them beyond a day or two. And if you give conditioned media from MSCs, they're just as effective or even more effective in their therapeutic approach to treating whatever organ injury. We have shown in 2012 that the therapeutic vector, at least for the model that we used of hypoxic pulmonary hypertension, the therapeutic vector from the MSCs was exosomes. So what are exosomes? They're phospholipid enclosed extracellular vesicles. Every single cell releases vesicles. These are extracellular vesicles, and they're different sizes and they're different types. And initially, when these were studied, they were thought to be the garbage disposal of the cell. Well, it's true. You do dispose garbage through these vesicles. However, they are important signaling molecules to communicate from one cell to the next. There are multiple vesicles, as I mentioned. There are some that are microparticles, large size, or called microvesicles as well. The exosomes actually are a unique class of these extracellular vesicles. And what they are, they're made in a sort of three-step process via the endosomal pathway. So since 1987, when we refer to exosomes, we refer to extracellular vesicles that have been produced through the endosomal pathway. Note those that butt off the cell membrane, for instance. And so you have endocytosis, and within this endosome, you have intraluminal vesicles that are formed, again, through this membrane. In this process, by the way, as you can imagine, you have cell membrane components, but as you're going through this process of endosomal formation and intraluminal vesicles, you're also taking in proteins, taking in lipids, RNA, microRNA, non-coding RNA, DNA, lipids, and they're packaged in these vesicles, which then fuse with the cell membrane and are released. And when they fuse with the cell membrane and they are released, they are now called exosomes. So again, the exosomes are through the endosomal pathway. And the exosome is the size attributed to the exosome is around 35 to 100 or 150 nanometers. Larger than that are really microparticles and apoptotic bodies, let's say. They're more than 500 nanometers in size. So the smaller size is the size of the exosome. And there are other non-exosomal vesicles that also have the small size. So it's a very complicated story. But what I'm showing here is that you have to show through EM the size of the exosome, and there are different sizes. But also what is shown is that the exosome contains the cell membrane proteins, the tetraspanins, also contains proteins that are critical for the endosomal pathway, like ALEX and TSG101, annexins, and other proteins. And exosomes have been used, if you look at the literature, to target a number of diseases of just about every organ. So we in the lab are isolating exosomes in as pure way as possible. The standard, and most people up to now, including us, have used sort of differential centrifugation and ultracentrifugation as the last step, so you actually get the small exosomes, but with that you get just about many other proteins and other contaminants. So it's not a pure population of exosomes. So we've done a size exclusion chromatography, and in this case what we've done is through initial clearance of the supernatant of these MSCs, we actually do tangential flow filtration and concentrate the conditioned media 50-fold, and then place it on an OptiPrep or iodixonal gradient, density gradient, and then we isolate several fractions. And the fraction, which I highlight here, F9, which has the density, corresponds to the density of exosomes, is the one that we reproducibly use for all the experiments. And this fraction 9, you see here, it's isolated from MSCs from Wharton's jelly. It is isolated from MSCs from the bone marrow, and is isolated from human dermal fibroblasts. We are using human dermal fibroblast exosomes as a control exosome, basically. And as you can see from the EM, they look identical. You can't really see which is MSC-derived, which is fibroblast-derived. And so we also did Western blot analysis for the proteins that I showed you on the previous slide are within or come along with the exosomes. And you can see that these tetraspanins are mostly present in fraction 9 in this preparation, fraction 9 here, and fraction 9 here. So the experimental model that we do use is the model of is the rodent hyperoxia model. Sorry, Dick, I cannot ventilate these mice. But as we heard today, it is one accepted model of BPD. And I will say that the neonatal mouse, like the neonatal rat, at least the level of lung development or the state of lung development is the saccular stage, which does correspond to the premature infant we take care of in the NICU. So there's some positive aspect to this model. You expose these newborn animals to high oxygen, and in our case, we use 75% oxygen. We've done 85, 95. We're settling on 75% oxygen on the first day of birth. On postnatal day 4, we actually give our exosome treatment, and we give it intravenously through the superficial temporal vein, which is very tiny. And then on postnatal day 7, they come out of hyperoxia and they're allowed to recover normoxia, just like the human baby. Even after they're out of the NICU, or even after they're out of oxygen, I should say, they still have lung injury that's present. The same thing happens with this model. If you follow them for months later, they still have abnormal lungs. So we allow them to recover normoxia, and at various time points thereafter, we assess their lungs. At the later time point, we also do pulmonary function tests and assess the pulmonary hypertension with cardiac ultrasound. I should mention that the dose of exosomes we give is a little bit arbitrary, but it's extrapolated from our studies using cells. And it's very difficult to really quantify the exosomes. As I mentioned, it's not ultra-pure population, and other proteins come along with it. So just looking at the protein content doesn't really tell you if you have enough exosomes. So we finally settled upon using the exosomes that are isolated using the same method from 500,000 MSCs. We do nanoparticle analysis to quantify the number of events, which corresponds to number of exosomes, but nonetheless, this is the method that we use to normalize between one experiment to the next. So after giving this single dose intravenously to a 4-day-old pup in hyperoxia, what you will see, the analysis at postnatal day 14. So they've been out 1 week from hyperoxia. This is the normal lung, honeycomb appearance, and this is the hyperoxic lung, emphysematous, as shown by others previously. And so down here, on the same day, we gave the exosomes isolated from the Wharton's jelly MSCs. The lungs are very similar to normoxic lungs. The exosomes for bone marrow derived MSCs, very similar effect. And the exosomes from the human dermal fibroblasts. And this is the mean linear intercept is quantified here. I want to point out, and we've seen this before, that the fibroblasts actually have a little bit of therapeutic efficacy. I can only speculate that they may contain some stem cells, and that may be the reason, but I haven't really proven that. But other groups have seen the same thing. So if you step back now, lower magnification, and look at the lung lobe, this is the normal lung, postnatal day 14. This is the hyperoxic, emphysematous, and large lung. And this is the hyperoxic lung that received, in this case, Wharton jelly MSC-derived exosomes. So if you look now later, I showed you at 14 days, what happens later? Pretty much the same results. Here's the normoxic lung. This is the hyperoxic lung. It's still abnormal and emphysematous. The exosome recipient lung, this is Wharton's jelly MSC exosomes, close to normal, and the same thing with the bone marrow. And this is quantified here on the right by mean linear intercept. We looked at evidence of fibrosis for collagen content. Now, in this model, it's not severe BPD. It's very mild fibrosis, trying to sort of simulate the human scenario. Nonetheless, there's mild fibrosis that's evident only in the hyperoxic animals and not in the treated animals. So looking at the vascularization, pulmonary hypertension is another component of this disease. Here's the normal vessels. Here are the hyperoxic vessels, smooth muscle actin SMA staining, smooth muscle actin. And then the animals that receive the MSC exosomes, the staining is far reduced and comparable to normoxic animals. So the vascular remodeling is suppressed or inhibited. And not only is the remodeling suppressed, but the number of vessels are restored. We heard earlier from Steve Abman how angiogenesis may actually drive alveogenesis. And so having a normal number of blood vessels is critical to the lung development. So here a normal lung, and this is von Willebrand factor staining. and outlining the vessels. Hyperoxic lung, less number of vessels with the arrows here. The hyperoxic lung that received the exosomes, you can see more vessels, and that is quantified here in a blind fashion, or somebody who didn't know the treatments, as to the number of vessels that are present. We did look at long-term pulmonary function. That's also important, and this is something that pulmonologists, pediatric pulmonologists trained us to do. Tom Martin in particular, we're grateful to him. So basically, this is a pressure volume loop, and this is the normal pressure volume loop, the blue line of the normoxic lung, normoxic mouse. And the red line is that of the hyperoxic mouse, which has emphysematous lungs. It's up and, whoops. So it's up and a little bit to the left because there's more air trapping. And then the green arrow demonstrates that the pressure volume loop of the hyperoxic mouse that received exosomes is closer to the normal pressure volume loop. And I should say that this was done on postnatal day 42, and by echo, I don't have the slide here, pulmonary hypertension is completely reversed. So we looked at now whole lung mRNA analysis and at postnatal day 7 and trying to focus on markers of inflammation. And basically what is seen here in whole lung, as I said, these two lanes are the hyperoxic lung, and these lanes on the right are the normoxic lung. So the inflammatory genes are expressed in a very different manner. They're pretty much overexpressed under hyperoxic conditions. And what I want to emphasize in the middle are the animals that receive the mesenchymal stem cell exosomes. And as you can see, the inflammatory profile, so to speak, the level of expression is very similar to the normoxic animals. Now, if you look at what genes are expressed and what pathways are being affected, which is always sort of a difficult thing to put together because it's a mishmash of pathways. There's cytokines, there are proteins involved in genes involved in granulocyte, encoding proteins in granulocyte migration, leukocyte migration, cytokine production, macrophage mediated immunity, and regulation of inflammation. So then we focused on macrophages as key, really patrol cells of the lung milieu. And first of all, we showed that in culture, this is an alveolar macrophage cell line, which readily engulfs the exosomes. And when we then try to see whether the exosomes alter the macrophage phenotype, we first looked at an in vitro experiment or in vitro assay where we isolate bone marrow derived macrophages and we polarize them to the M1 or pro-inflammatory phenotype, and you can do that in culture using standard methods that have been published, but basically you stimulate them with IL-1 and interferon gamma, and so you have high expression of M1 cytokines such as IL-6, such as CCL5, such as TNF-alpha. And what you will see is that the cells that were treated with these M1 polarizing agents, but with exosomes, the IL-6 is suppressed, CCL5 is suppressed, TNF-alpha is suppressed. In contrast, the human dermal fibroblast exosomes actually superinduced inflammation. And then we looked at another phenotype, and let me just make a statement that it's not just M1 and M2 in macrophages, it's the whole spectrum. And there's a high recognition now for the pro-resolving or M2R macrophages, which actually play a critical role in BPD, in resolving BPD. In this case, the M2 phenotype actually leads to remodeling. And what we're finding is that once you polarize towards M2 in culture, you are inhibiting this with the exosomes. This is a marker of M2 marker, CD206, and retinal A is another one. And this is not affected by the fibroblast-derived exosomes. This was in vitro. We wanted to see in the treated lungs, was there any change in the macrophage phenotype of the lungs? And indeed, the pro-inflammatory M1 phenotype was suppressed at postnatal day 7. You will see that there's not much inflammation happening at postnatal day 14. But at day 7, IL-6 is suppressed, CCL2 is suppressed. These are M1 markers. CD206 is suppressed, and arginase 1 is also suppressed. These are the pro-remodeling M2 macrophage markers. So we talked about inflammation, we talked about macrophage phenotype. I've also mentioned there's fibrosis, and the model that we're using for fibrosis is really minimal fibrosis. So we decided to look at another well-established model of fibrosis, which is the bleomycin model of fibrosis, in which case, these are adult mice, by the way, and bleomycin is administered intratracheally. And the exosomes we administer intravenously at the same time. This is through a tail vein injection. And in this case, exosomes are from 1 million cells. So these are bigger mice. We gave double the dose. On day 0 of the bleomycin administration, we analyzed day 7 and day 14. And first, let me point out that the bleomycin-treated animals, which is in red, lost weight between day 0 and day 14, and that the animals that received the MSC exosomes did not gain weight, just like the control. So that was the first data that was promising. And then we just looked at the whole lung for fibrosis. Here's the bleomycin lung, and here it's in higher power. There's lots of patchy fibrosis. And what is really, really remarkable, I mean, I didn't expect this, is that the single dose of the exosomes pretty much completely abrogated the fibrosis. So this is a very severe injury, and this is completely prevented. So we're saying inflammation, macrophage phenotype, we're saying fibrosis, all these are affected. And I also said that it's a mixture of exosomes, and they're definitely different sizes. So we tried to get to this. Are all sizes of exosomes equally effective? All types of exosomes equally affected? And I'm talking about MSC exosomes because the dermal fibroblast exosomes do not work. And so we did various methods. This is a sucrose gradient and nanoparticle quantification, and I isolated each one of those fractions and basically looked for markers that are associated with exosomes. And what we noticed is we got 2 different peaks of exosomes. This is like the F9 fraction that is separated. And we have one fraction here that we call Fmex and another fraction here that we call Amex. And the Amex express TSG101 and ALEX. Remember, these are important in the endosomal pathway of making exosomes. And these markers, CD9, CD81, are tetraspranins. They're also present in exosomes, but they're present in other extracellular vesicles. So at least within this F9 fraction, we know that there are 2 types of populations. Are they equally effective is the question. And to answer this, we looked at fibroblast to myofibroblast differentiation, looking at lung fibroblasts, and just looking at baseline cytokine production. And when we cultured the fibroblasts with the Amex, their baseline production of IL-1 beta and CCL2 was suppressed, whereas Fmex really had no effect. And in this case, we tried to stimulate the myofibroblast phenotype in culture, and that's using TGF-beta, which is a known inducer of myofibroblasts. And a marker of myofibroblasts is Pi1 mRNA, and that is induced by TGF-beta, and this is significantly suppressed by the Amex, but not by the Fmex. So there are different populations. One may be more active than the other. At least in this assay, we need to test them in many other assays. The process of separating them and getting enough amounts is very laborious, and therefore we don't have huge material to work with. So in summary then, what I've shown you is that a bolus dose of purified human MSC exosomes from 2 different MSC sources effectively alleviate the core features of hyperoxia-induced BPD. They improve lung development, associated pulmonary hypertension, and long-term lung function. MSC exosome suppresses hyperoxic inflammation, modulate lung macrophage phenotype, inhibit myofibroblast differentiation, and overall, we believe, promote lung homeostasis. My belief, the more work I do on this, is it's not just an anti-inflammatory effect. And inflammation is actually good for you depending on the stage that you're at. So you don't want to knock down inflammation completely. You want to modulate it. And I think in some mysterious way, these MSC exosomes are able to modulate inflammation and to alter the lung milieu to restore homeostasis. And I'll be spending the next several years trying to figure out how that happens. So what we're suggesting that MSC exosomes provide a novel platform for therapeutic intervention in BPD and potentially other neonatal disorders with common pathogenic pathways of tissue inflammation and injury. And I'll just say we looked preliminarily at the eyes of these mice that were exposed to hyperoxia plus or minus exosomes, and they have absolutely no ROP. It's completely reversed. So, but I'm not an ophthalmologist, and I'm hoping the ophthalmologist will help us figure it out completely. There are many unanswered questions. So we definitely want to test MSC exosomes in clinical trials. MSCs are being used in many trials. These are product of MSCs, so theoretically they should be safe, if not safer, and FDA needs to be convinced of that. But we do need a high-quality product. Biomarkers of efficacy are really needed. Potency assays are needed. We're working on that, and maybe the macrophage phenotype is one of them. For a clinical trial, what is the right patient selection? I mean, after today's meeting, I'm even more confused than ever in terms of how do you choose the right patients. You have to do no harm. It's a new first-in-human trial of a product, but you don't want to treat somebody who's already dying. You don't want to treat somebody who's not ill at all or is never going to get the disease, but who should you treat? And that's a little bit of a challenge. The timing, the dose, how many doses? Certainly in the rodent, 1 dose is sufficient. In the human, I highly doubt that. But at least for the first trial, we would not be looking at efficacy. And what is the best route of delivery? I propose intravenous is the best way because it's one-stop shopping. You're going to get the brain, you're going to get the eyes, and you're going to get the lungs. The kidneys as well, by the way. I don't study the kidneys, but maybe they are also affected. The long-term follow-up is absolutely critical, and it's more than 6 months. It's more than 1 or 2 years. It's lifelong, basically. So I was, in my mind, debating, do you just continue studying this in the lab in preclinical models and basic molecular biology and biochemistry and keep going? And I think what I'd like to do and what I think is probably the best, the better path to take is to continue rigorous study and rigorous characterization of these exosomes, keep testing more preclinical models, and I'm happy to say that with Kurt Albertine, we're going to do the lamb, which is ventilated. So it's another model that hopefully will answer some of the questions. But at the same time, I do think that this is a disease that is getting worse. The severity is not getting worse, but the prevalence is not going away. It's increasing. So we do need to think for different modes of therapy, and I think regenerative medicine is the way to go right now, at least one of the approaches. So I want to thank the members of my lab who have done most of this work. Gareth Willis has really done 90% of the work on this, on the effect of the characterization of the exosomes, and then the model was established by Angeles Fernandez-Gonzalez. Nahal is doing the work. She's actually a pulmonary fellow who just started in the lab for 6 months, and she's almost finished the bleomycin model. Alex Mitsialis is the director of the lab, and he's really the brainchild. He's the exosomes is something that he has really taken from the beginning to this point. And Elizabeth and Vincent are the new members of our lab who are very interested in exosomes and want to cure every disease, but that's a lot of hope, and we need to do a lot more work to answer all these questions. So I'm happy to answer any questions you might have. Thank you.